Hi there, everybody, and thanks for joining us. I'm Elizabeth Din with this KOIN conversation, and I do also want to welcome with me right here, and this is Dr. Mary Ann Garvey Loveland. Thank you for being here. OBGYN, physician and surgeon with Women's Healthcare Associates here in the Portland area. And am I correct that you have 11 different offices? Not you, but Women's Healthcare Associates.
We do. We have 11 different offices throughout the Portland metro area, all the way from Newburgh to East Portland, to an office near Good Samaritan. We have Oregon City. I have great colleagues, coworkers who work at all these offices. We have Northwest Perinatal, that's our high-risk pregnancy center. So a lot of really great people who work at all of our clinics.
Yeah, and you've been doing this for 19 years with Women's Healthcare Associates.
17 years, all with Women's Healthcare Associates that I've been here in Portland. I grew up in Portland, so this is where I wanted to come back and convinced my husband this is the place to be, and been really happy here for a long time.
Congrats on 17
Thanks.
years, and thanks for being here. The topic that we're talking about today is something, for me personally, and a lot of girlfriends in my life, it is about perimenopause and menopause. And I think a lot of people can get confused about it, and then it's like, am I in the right age to talk about that? I think that's why we have so many questions, and I know you have all of those answers. So thanks for being here to talk about that. I want to start with like the most common myths that you want to dispel. And, you know, I think you sent me some notes about this too before our conversation. Realistic expectations with what is called MHT. And I wonder if PHT might be like another term we can use too. Things that can help. What can we try? I guess let's start with first like the myths that might come up, like what's true and what's not in terms of like perimenopause and menopause.
Yeah, so there's so much to talk about, Elizabeth. It's almost overwhelming, and but I think it's important that people know about it and people get to know about it and be able to ask questions about it. So I think one of the biggest myths is that either people are too young to experience perimenopause or menopause, or we were just talking about this before we went on the air, is that menopause ends sometimes. Menopause is with you for the rest of your life. You have effects on your brain, on your bone, on your cardiovascular health that are with you for the rest of your life. So it's really important to be talking about these things. The other big myth is that there's a holy grail, that there is this fountain of youth that you're going to take estrogen therapy or some other form of hormonal therapy, and it's going to solve all of your problems. That's just not true. But there's so many things that we can work with for different issues that people have. And also, I think people deserve a really detailed conversation and a really specialized plan with their healthcare provider.
I was just showing some video just now of some of those things that people take, which are, I think we can go into that a little bit.
Yeah.
Which is, that is the patch, right? And I say the patch, but the most common patch, I would say, like not the patch, but an estrogen or hormone, that's HRT, hormone replacement therapy. I think these terms are all in that same circle. That we can start with that one.
Yeah, so an estrogen patch is a transdermal or usually I prescribe a small estrogen patch that goes on either once or twice a week, depending on what brand or dosing you get. And that's really meant to help with a lot of different perimenopause, menopause symptoms. Very effective at preventing hot flashes, night sweats, can help people with better sleep. Some people really are reporting better changes in their mood, less brain fog, joint pain. We absolutely do know that it prevents osteoporosis, which is a huge thing that we really need to talk about more with women. So these are all things that an estrogen patch can help with. It's really important that an estrogen patch always gets paired with a progesterone, because estrogen alone can cause cancer of the uterus. We do not like that. So if you have a uterus, it's really important that you also are on a progesterone to protect the lining of your uterus. And I'm going to use the term menopausal hormonal therapy or estrogen therapy or progesterone therapy. The term hormone replacement therapy, it's a little bit some of us who are in this field think it's a little bit outdated or a little bit misogynistic because we're implying that there's some kind of deficiency. We don't call puberty a deficiency. There's a change in hormones. So we try to say menopausal hormonal therapy when we're talking about this.
Okay.
Yeah.
And I know I had heard, I think I want to say like probably a podcast or conversation, and it was that doctor was saying that for a long time, and am I right that more people are talking about HRT and hormones?
Yeah.
Because for a long time there was fear, and then there was the C word of cancer.
Yeah.
Can you explain this better?
That's a huge, really important thing to talk about because that's along with the myths. All right. So when we look at the history of hormonal therapy, we always talk about a study that came out in 2002, the Women's Health Initiative. And this is a really important study that studied a huge subset of women. And the primary outcome of this study was not to show that hormone therapy prevented hot flashes, night sweats, but it was to see if the indication for which all women were going on hormonal therapy at this time, prevention of cardiovascular disease, was the right thing to do for women. And what they did in 2002 is they halted the study early because they found that appropriately it did not prevent cardiovascular disease. In fact, it increased cardiovascular disease, increased risk of blood clots, increased risk of cancer, breast cancer, that is, and that's the headline that went out, okay? And when you're talking about an event that's so rare, that risk looks like it's high, but the absolute risk is actually really low. So what they found is an extra 6 women per 10,000 women who were in the study got diagnosed with breast cancer. An extra 6 women per 10,000 women had cardiac disease. But we also have to look at who this study included. The average age of the study was age 62, not 40s, not 50s. Half of those women were smokers. So we actually have to look at that data. So it was a good study. We got a lot of good information about it because we did appropriately say that our primary outcome should not be prevention of cardiac disease, although we're seeing that hormonal therapy is cardioprotective for women who start hormone therapy early, like within 10 years of onset of their final menstrual period. But the absolute risk of breast cancer is low. So that should have been the overall headline. It's not zero, but it's low. People were really scared away from hormonal therapy for a long, long time. And I have to say, honestly, my coworkers were scared to prescribe it because there were lawsuits that were going on with prescribing hormonal therapy. So many of my older colleagues who had lived through this were really frightened to prescribe it because they'd had lawsuits brought against them. And we have a litigious society. So I can imagine that definitely impacted their medical practice, and it impacted a lot of, like all of my aunts and my mom's friends. They went off of their hormone therapy back in 2002 because that was the headlines in the New York Times. It is scary when you hear the word cancer, but the absolute risk of cancer is low. I always want to make sure my patients are up to date with their screening mammograms, talking to them, making a personalized plan for their breast screening. Do they need additional imaging? What's their breast density? What's their family history? Do I need to send them to a genetic counselor to talk about risk of breast cancer? But it doesn't preclude them from using hormonal therapy, menopausal hormonal therapy.
Let's talk about when people should start thinking about it, because you talked about that. Obviously, I think we would talk with our doctors about potential dosage and do you go up or down. But how about prevention? Because I feel like there are so many people, and maybe you're the same way, of like, hey, I wish that someone had told me, or I had known sooner, or I have colleagues and friends who are maybe in their 30s, and it's like, I hope this doesn't happen to you, or you don't have these symptoms. But regardless, I think so many of us who are going through it or have, we're now like, we're wanting to let others know preventative measures. What's your advice to those women, or what we're trying to give to our friends and colleagues?
Yeah, I would say talk to your friends, talk to your colleagues. There is a lot of information on social media about this. Some of it's great, some of it's predatory. That's the really, I think, sad thing about it. It's really hard to tell, and I talk to my patients a lot about this, and I'm like, it is definitely a red flag if someone's trying to sell you something. It is a red flag if someone's trying to sell you a supplement or telling you that this is the holy grail and going to absolutely make you lose weight, have a better sex life. There's a lot of great things about hormonal therapy, and there's no need to sell people supplements. So I think opening dialogues like this, I think that we have a lot of information on our website at WHA about it. I really encourage people to, luckily live in Portland. I know people, maybe some of your viewers in other areas maybe don't have access to maybe an OBGYN who's familiar with menopausal hormonal therapy. But there's so many physicians, nurse practitioners, midwives here in Portland who really practice great evidence-based care through Women's Healthcare Associates, Providence, Legacy, Kaiser. I have a lot of great colleagues at all of those places who practice really great care. Talk to your doctor about it. Talk to your primary care doctor about it, your family practice doctor. If they don't have information, they'll refer you to me and my colleagues who have more information about it. So keep pressing. Keep asking questions. Be careful of what you are getting through social media.
Yeah.
But there are some great social media people out there, too. So that's what's hard, but it's also interesting, and we're here for it.
Myself, having gone through other health issues myself, for example, I mentioned it's not a secret, I'm a kidney transplant recipient. And so for me, I'm so hyper aware. And my thing, people have asked, like, how do I know if I have kidney failure? Or,
right.
How do I know? I always say, like, obviously be self-aware. If you're unsure, go to a doctor.
Yeah.
So I can only give you so much, but if you feel something's off, a doctor will be able to answer those questions. And I think you would agree with that.
Yeah,
you
definitely. I also tell people, you're the one living in your body. You're the one who's going to tell me if something's wrong. Hopefully you can see me once a year, a few times a year. I definitely see people more for menopausal hormonal management, which I think is great, more than once a year for that. But trust your instincts. I think that is a great advice. And if something's not right, and there's not always an immediate solution. Sometimes we need to work through it. You need dose increases. We need different kinds of progesterone. You'll have a side effect, but we're here to work with you.
A little bit about prevention. I think one is prevention before, if you go through the symptoms, if you do, because like we said, not everyone goes through them. And if you're going through it, let's talk about the importance in your notes here: lifestyle, exercise, diet, which then goes into sleep.
Yes.
Our mood. Talk about the importance of all of that. I think no matter the stage, these are all like really good pieces of advice, right?
Yeah, they are. And we see with people who live the longest, they are active. They walk, they have social connections, they have purpose in life. They eat mostly vegetables, which is always a good thing. So, we really, like, nothing can beat lifestyle. Like, I could give you an estrogen patch and progesterone and talk to you about testosterone, but really exercise and having an active lifestyle, not just sitting down. But, I'm like everyone else. Like, I didn't wake up early to work out. So I think, where's the next opportunity? Who can I meet for a workout? Like, there's ways to go for a walk with my kids, go for a walk with my dogs. So those type of things, weightlifting, weight-bearing exercise, so important. What we see, and there's some really great people who have a lot of literature about this. I encourage everyone to check out Dr. Stacy Sims. She's an exercise physiologist, a PhD, who really talks about for perimenopausal women, how we really need resistance training. That's where we're going to get the best bang for our buck, is really lifting heavy weights, lifting more than you think that you can lift with shorter intervals. I know growing up, I was just taught cardio, but now trying to incorporate weights. And also that's going to behoove you for the rest of your life, because we know that osteoporosis prevention is with weight-bearing exercise. So we want to keep people mobile. We want to keep them active. We want to have people be able to do the things that they want to do to live a long and productive life.
I'm down to about 6 minutes left, so hopefully we can fit in a couple more topics. One is about how do we know, if menopause, does it ever stop, and do we need to, because I think some people might be like, I don't want to be on medicine for the rest of my life, and so how do you answer that question?
I think that that's a really nuanced discussion. There's so many people who do just fine without hormonal therapy. They are able to lead long and productive lives. They don't get heart disease and osteoporosis. They focus on exercise, diet, weightlifting, social connections, and sleep. And then there's people who do really, really well on estrogen and progesterone therapy. And it's a nuanced thing, and it's not a one-size-fits-all kind of thing. And being able to have those discussions about how long should I be on this? My take is that I see patients every year and I keep assessing their needs. And we decide together, has your health history changed? Are you having benefit from this medication? Are you having less joint pain, hot flashes? Are you sleeping better? Is your mood better? We're going to keep assessing that year by year. So I typically don't have a stop date for my patients. We do know that there are benefits to being on estrogen for long periods of time, especially with bone health. Estrogen and progesterone.
Okay.
Yeah, always together. If you have a uterus, always together. They're besties.
For those who don't have a uterus?
Estrogen alone. Estrogen alone. Some people we do put on progesterone because micronized progesterone can help with sleep, help make people sleep a little bit better. So that's also a nuanced discussion to have with your physician. But
I heard about testosterone.
so testosterone exclusively for postmenopausal hypoactive sexual desire disorder or low libido, and hasn't been. There's some controversy about this on social media, and there's some people who really are proponents of testosterone for everyone. The Menopause Society, really the evidence-based care is that it should be exclusively for postmenopausal low libido. And there's not, unfortunately, an FDA-approved product for women. I have great hopes that there will be at some point. So I either provide a compounded product through really reputable compounding pharmacies in Portland, or I do a tenth a dose of a male testosterone gel product for patients and check their testosterone levels about every 6 months.
And it circles back to that, what we were just saying earlier. If you're not sure, ask your doctor.
Ask your doctor. Ask your healthcare provider. You deserve a nuanced conversation about this. Don't make it at your annual exam. We have so much to talk about at your annual exam. If you start the conversation, I like to start the conversation a lot at annual exams and then make a follow-up appointment. And a lot of these can be done by telehealth because I've already done your physical exam. We've done your pelvic exam. We've done your breast exam. We make sure you're up to date with your cervical cancer screening. We talk about what labs to get as far as health screening. Make sure you're up to date with your screening colonoscopy. All of these things. Lots to do.
I wanted to add that you also were so great in that you had written a few blogs about this too. And so this is something that we were showing a couple, you and a few of your colleagues there at Women's Healthcare Associates, which we're showing on the screen, write these articles, these blogs, which I think is really great that you and many other doctors are starting to do, which I think is so helpful. Like this, for example, symptoms of POI, which is also, does it have to do with the ovaries?
Yeah, premature ovarian insufficiency before the age of 40, going through menopause, which is a really serious topic. We really want to see people and talk about that.
So I'm grateful that you and your colleagues have written these, and so people can look them up, and so whether they're your patient or not, start researching online. But you know, if you don't know, as you were just saying, for sure, then of course see the doctor. This is a great start to start doing that research because it comes in many forms. It's like I've seen podcasts, I've seen articles, blogs, what we're doing right now, which is great. So I wanted to highlight that you'd written those, which is really great, that we were able to show those as well. I'm down to just like a minute and a half. I just wanted to close out with something different, but I was reading about you that before you became a doctor, you wanted to be an astronaut.
Yes. Oh my gosh. But that was very short-lived. Very short-lived.
You're clearly curious though, which I think is great for a doctor and from the patient perspective, right?
Yeah, there's so much to learn. I'm learning every day. I'm learning from my colleagues. We really do learn from each other. We ask each other questions. There's always new research, which you have to be curious. Like you said, you have to be open to changing your opinion. I recently found more evidence about safely treating with menopausal hormonal therapy after people have had a cardiac event. that might be a safe option. So, changing your opinion based on the available evidence and research. But also, I think patients need to know what their risks are in order to make an informed decision and have a nuanced discussion about their individual risks, even though those are low, but it's an important discussion to have.
Again, Dr. Marianne Garvey-Loveland with Women's Healthcare Associates. Thanks for being part of this KOIN conversation, and I really
Thanks,
hope,
Elizabeth.
You guys, that this helps many of you out there. And then even if you're not going through it, that you let people know about this and that you're educated, right? Like spouses and kids, like you can understand by watching this episode. So thanks everybody for tuning in, and thanks to Marianne and her colleagues at Women's Healthcare Associates.